I'm very happy to be joined by two great colleagues. You've already heard them introduced just a bit, but I'll now take that a step further. So first, we have Susan Domchek from the University of Pennsylvania. Susan's a professor of medicine at the University of Pennsylvania and focuses largely on BRCA1 and BRCA2 and other hereditary aspects of breast cancer. I will confess that Susan was once my mentee when she was a fellow at Dana-Farber just a few years ago. I won't say how long ago that was, but it's long enough ago that Susan is now a world-famous breast cancer researcher and clinician. And also joining the panel is Dr. Constance Lehman, who is my colleague in Boston. And Connie is one of the world's most outstanding breast cancer imagers. And she has piloted and further investigated many novel imaging technologies. She's been involved in the area of artificial intelligence and breast cancer screening, and her comments will be particularly helpful for those women who are interested in hearing about how best to monitor for breast cancer. So without further ado, we have about a dozen pre-submitted questions, and I'm just going to start, and I'm going to say to all of you that we're going to try to keep this as informal as possible. It's a little funny doing this by Zoom or whatever this particular platform is, but we're going to do our very best, and I'm sorry to say that over the past 8 months, all of us have gotten used to communicating in this way. So Susan, I'm gonna start with you, and you can take this question any way that in any direction that you want. But have there been breakthroughs in screening and prevention of hereditary breast cancer? I think Connie may want to comment about some of the screening aspects, particularly regarding imaging. But what's new in hereditary breast cancer?
Well, Eric, it was very kind of you not to date me, but I'll date myself, which is I graduated from medical school in 1995, which was when BRCA2 was cloned. And since that time, we've had an increasing understanding regarding genetics and genetic susceptibility, and also the concept that we've always known that genetics isn't everything, but genetics can certainly help us. So we've expanded from knowledge about BRCA1 and BRCA2 into multiple other genes called PALB2 and CHEK2 and ATM. And increasingly, we're also understanding changes in the genetic code, which have tiny little effects individually, but all together can have a great impact. We call these single nucleotide polymorphisms. We talk about polygenic risk scores. And what all of this means, and which is why it's going to be so interesting to talk to Dr. Lehman tonight, is that we want to use this information to risk stratify patients so that we can determine who needs screening when. So people who have BRCA1 and 2 mutations need the maximal screening. They need breast MRI in addition to their mammograms if they're not choosing mastectomy. But there are actually some women in the population who likely need less. They actually may need a mammogram every other year. And it's important to kind of differentiate who needs more and who needs less. And genetics is one piece of that, as is breast density and other things that I'm sure we'll talk about tonight.
Connie, do you want to just touch on screening issues for women who are at particularly high risk because of a genetic predisposition? And I'm going to ask you to comment about one very specific issue, since I'm sure you're going to talk about MRIs. And a question that many women ask over and over again is, if I'm having MRIs, do I still need to have those uncomfortable mammograms?
Well, absolutely. And, you know, there's sort of a foundation of truth that we know, which is that when we detect cancers early, it's much more likely we will cure them, and much more likely the impact of the treatment will be lower. And we have decades and decades of research in mammography, and mammography itself has gotten so much better. When I pull even old comparison mammograms from 1990, I have to remind myself, we used to think that those were really high quality exams, and we can go back to the late 1960s when we were first screening, and we can't imagine they were able to find anything. And for all of the problems and all of the challenges of mammography, the missed cancers, the discomfort, the concerns about radiation, it still is the best tool we have for early breast cancer detection. It's the standard against which we keep trying to get better things. And so we want to remind women, it has problems, but it really is the best test we have. And we still strongly encourage women to get their routine mammography. The question in the domain of MRI is really important. And I'll cut to the chase a little bit on what I'm most excited about in the domain of MRI. I spent most of my career studying MRI. The clinical utility of it. We were surprised that in some patient populations where we thought it would be a great tool, it didn't work that well. And others where we thought it'd be sort of a lousy tool like screening, it actually worked really well. But we also found out over time that very few women had access to the quality MRI programs that we thought would bring such benefit, and that there were problems with MRI as well. There were problems with false positives, women that just didn't tolerate the MRI well. And really what the MRI was doing was showing us areas where there was abnormal or different or increased blood flow at very focal specific spots. And it's that increased vascularity that we were looking for with the MRI. So we're pretty excited about some new methods of vascular or imaging that shows this increased vascular spots, such as contrast-enhanced mammography. And I think that's going to be a very important development in the next few years, is how can we provide greater access to contrast-enhanced mammography. My gut instinct is the reason why a long time ago we thought contrast-enhanced MR wouldn't be a great screening tool is because of the expense and the challenges in having global access or access in a diversity of communities across the country, really high quality breast MRI. And I think contrast enhanced mammography might cure that. But you also asked, do you still need to get a mammogram? I actually think you do. I've got some really bright colleagues, especially in Europe, who think that you might not need to, that the MRI itself would be sufficient. But we still see certain types of cancers, especially the early ones that we still like to know about, the ductal carcinoma in situ or the BCIS, or we're going to just see it, many of those cases better on the mammogram. So a little bit globally, and if you talk to experts around the world, the jury's still out, but especially in US centers, we really want women to continue the mammogram along with the MRI if they're at high risk.
And just as Mary gives us an opportunity to look twice in a year. So we tend to stagger them so that every 6 months a woman is getting either an MRI or a mammogram, and that makes me feel better. And we certainly have detected things on those interval mammograms. And again, we're talking about women at the highest risk. Not everybody needs an MRI. I'm sure that we're going to be talking about that more too.
And I also like, Susan, what you were saying about how we're really trying to move to precision medicine. We're trying to be more precise. And as we're looking at all of these different factors that you're developing with your team and that you're testing and studying, it's, which women really need more intense screening and which can do really well with less intense screening. And what we're excited about, and what I love about the BCRF, always approaching this from a multidisciplinary perspective, is that we're looking not only who's going to have cancer, but which of these screening modalities best suits these different women. We're pretty basic in that right now. Like someone with very dense breast, we're saying, well, the mammogram may not be as good as an ultrasound or an MRI. Where someone that has totally fatty breasts, it's like, oh, the ultrasound might not help. But that's just scratching the surface of where we can really get to, particularly with some of the new tools that we have in our toolkit for being more precise about screening strategies.
And before we leave this, just going back to the pre-panel video, we heard from Nina Garcia, who acknowledged that she had a genetic predisposition to breast cancer and that she ultimately decided to have bilateral prophylactic mastectomies, which of course does dramatically reduce the risk of developing breast cancer. But do you think that there will be a future time when our screening and treatment is so good that a woman, and she is one of many, by no means unusual in that decision, but will there be a time when a woman doesn't need to make that decision because she can rest assured that if she develops a cancer, it will be caught so early and treated so effectively? And I guess I'd pose that to both of you.
Well, I'll jump in first and say, because I'll let Connie take the screening and early detection question, but let's not forget about prevention. And we definitely want to think about non-surgical prevention.
Yep.
There are really interesting studies that are ongoing or about to start in the US, and those include such things like a bone strengthener medication called denosumab, which preclinical data suggests that it may decrease the risk of BRCA1 associated breast cancer. We actually have FDA approval to start a vaccine trial in BRCA1 and 2 mutation carriers. So we don't know which of these things will work. PARP inhibitors may work, but we have to keep trying non-surgical prevention techniques, because if we can get our risk down by 50, 60, 70%, and then we have really good screening, then that seems like a really reasonable option. So we need to work on these things simultaneously.
And Connie, do you think we're going to see further advances in screening for women who are at very high risk?
Absolutely. We're really excited about this domain. And, you know, I agree. It's so interesting when we think back. I remember as a medical student, an epidemiologist was talking to us about cervical cancer and what the patterns that she had been studying and seeing. And she just mused like, you know, would it be possible that there could ever be a vaccine? Because some of these patterns, it looks like there's an infectious component because of the populations that were more likely to get cervical cancer and less likely to get cervical cancer. And here, you know, then here we are with the vaccines that just have dramatically reduced cervical cancer. So breast cancers seem certainly to be more diverse types, and there may be many different types of disease, but a vaccine against many forms would be so exciting. Interventions that can prevent many other types of breast cancers from even developing, and then the screening technologies that we have. I think we'll probably talk about it sometime this evening, but we're so excited in the imaging sciences, not only for how we can be more precise in screening, but finally being able to extract predictive data out of every woman's mammogram, out of her ultrasound, out of her MRI, that really helps piece together, are these interventions to prevent or reduce risk, are they working? Do we already see changes in these signals over time? So that marriage of the genetics and the imaging, it's the proteomics and genomics, it's an exciting time of big data.
And do you mind if I follow up on that? There's never going to be a problem with us talking too little. You've already had that. But, you know, we've always struggled in the prevention field that we do have a medication that decreases risk in the general population by, 50%. These drugs, tamoxifen, raloxifene, aromatase inhibitors, but people don't want to take them. And I understand it because there's side effects. And what we don't have is a marker to show people that it's working. And I try to remind patients that you take cholesterol lowering medications to prevent a heart attack and a stroke. You actually don't really take cholesterol medications just to lower your cholesterol. But in the breast, for us, we don't have that intermediate biomarker. And we're hoping that Connie and all of our colleagues comes up with it. Because if we can show people, you're taking this, and we can see that it's changing your breast tissue and reducing the risk, I think we'd have much higher uptake of our medications.
No, absolutely. So we'll come back to the whole issue of artificial intelligence and what you can learn from presumably, so-called normal mammograms a little later. So the next question relates to what's sometimes called de-escalation of therapy. And it specifically is, what is the de-escalation of therapy and how can this benefit patients? And I'm going to start with this, but I'm actually going to then turn to each of you about this one as well. So breast cancer research at the moment is sort of a tale of two paths. And one path is about trying to figure out why it is that some women develop recurrences of breast cancer, recurrences elsewhere in their body, that is metastatic breast cancer, and ultimately, sometimes after many years, die from breast cancer, which is absolutely what we want to try to prevent. And of course, there are some women who, even at the time of their initial presentation, already have metastatic breast cancer. We're going to be talking more about metastatic breast cancer later. And for those patients, much of what we have to study is how to avoid drug resistance, and how to come up with better therapies. But there's another very large group of patients who at the moment are absolutely cured with the therapies we have. And one of the big questions we have is whether we can actually do less and still achieve that same very favorable result. Because the truth is that all of our treatments have some side effects. Getting chemotherapy certainly has side effects. Taking 5 or 10 years of hormonal therapy has side effects. Surgery is not necessarily pleasant, and radiation has side effects, just to name a few. And so what de-escalation is about, and I actually don't really like the term de-escalation, although I may have been one of the people who coined it, is I like to call it right-sizing therapy. And what that's about is trying to come up with the right therapy for the right person. And in medical oncology, we somehow think that we've invented this idea. Of course, the surgeons and radiation oncologists have been asking these questions for several decades. But in medical oncology, what that has been about is largely trying to get rid of toxic chemotherapy. And we've done that successfully in many patients with estrogen receptor positive breast cancer, where we learned that many of those women who are diagnosed with estrogen receptor positive breast cancer have either little or in some cases no benefit from chemotherapy. And we've also been able to do it in another setting, in so-called HER2 positive breast cancer, where in fact we have medicines that are alternatives to chemotherapy. And these are drugs that are directed against the HER2 receptor. And there we can often use much less chemotherapy in combination with what are often antibody therapies. And that's particularly true for women who have early stage HER2 positive breast cancer. But I think the take-home message is that, and this is certainly true in medical oncology, is that we are very aware of the side effects that we induce, of the long-term toxicities that come from some of our therapies. And while in exchange for preventing a recurrence of cancer and preventing a woman from ultimately succumbing from metastatic breast cancer, those side effects may be well worth it. But if we can achieve the same result and ensure that a woman is going to do well, then it certainly makes sense to dial back on those side effects. I'm going to ask Susan to just expand on that a little bit. And then I'm actually going to ask, I'll say it right now, what I'm going to ask you, so you can just go ahead. I'm interested in Connie's thoughts about backing off on the frequency of mammography in some women, which is something that Susan referred to earlier. So, Susan.
Right, and this all interrelates to each other. When I was training under Eric as a fellow, every woman who had a 1 centimeter tumor that was estrogen receptor positive and lymph node negative, which is a low risk situation, we talked to every woman about chemotherapy in that situation, which is pretty incredible to think about now, because on the basis of large randomized trials, we now know that 75% of those women don't need chemotherapy. And we know it based on these genomic assays. The most common one in the United States is called an oncotype assay. And we know now that biologically, most of those tumors aren't at high risk. Sorry about the feedback. Maybe the two of us could, when we're not speaking, we'll go on mute and see if that helps. But so now we don't, for a node negative estrogen receptor positive tumor, most of those women, particularly if you're postmenopausal, don't get chemotherapy. And this relates to imaging because one of the downsides of imaging that has been proposed is that we find cancers that a woman might have died with and not of, and that we're overtreating all those women. But now that we're giving so much less chemotherapy, we have to kind of rethink about that a little bit because we're not giving chemotherapy to everyone. And so that's a really striking thing. I mean, the amount of chemotherapy we give now is so much less than what we gave before. And yet we are overall, women have better outcomes. I mean, that's pretty cool.
Yeah, I really like the way that you framed that, and I couldn't agree more. We keep looking, whether it's de-escalation or whatever the term is, it's trying to be more precise. It's trying to say, look, one size doesn't fit all. We have multiple different shoe sizes because of all the different kinds of feet around, and we're trying to do that across all the disciplines, med-onc, rad-onc, surgery, our genetic specialists, and in imaging. It's always interesting for me to think back historically when people, it's a very sensitive topic among breast imagers about when to start, how often to screen, and when to stop. If you want to get someone excited at a dinner table with a bunch of breast imagers, just open that topic up for conversation. If I go back to some really interesting advertisements from the American Cancer Society in the 1970s, it has a picture of this woman, and she looks a little bit like she's had a lobotomy, and she just looks like she cannot make any rational decision. And it says, if you're over 35 and you haven't had a mammogram, you need more than just your breast examined. You need your head examined. This was over 35 in the 1970s. Now we come forward a little bit, and the American Cancer Society comes back and says, well, we meant that you needed your head examined if you were over 40 and hadn't had a mammogram. And then they came back and said, actually, what we really meant based on the science was 45. So you can imagine that this has changed. Different organizations change. They review new data. They try to adjust. So it's been an area that has been so frustrating for so many women that just want to know, when should I start? How often should I have this test? And when should I stop? So we need to be more precise about it. Those of us that really work in the domain of breast cancer are so focused on early detection. Sometimes it's confusing to think, well, why wouldn't you just screen everybody every year, starting at 40 or starting at 35 or whatever the start date is? And it's because what Susan has said, there's harms associated with that. There's a lot of women who we may not know them as much. They've never had breast cancer, but they've had multiple biopsies, surgeries. They sort of had a big chunk of their life where they actually didn't feel particularly healthy. They might have stopped exercising because of their breast disease. And so my friends that are in primary care, they see these women more, and they are concerned about the impacts of, quote, over-screening. Over or under is all about, it's just not precise. And so I feel very confident that we are right at the brink of getting into more precise screening strategies for women. And I'm really excited about it. We've gone through a few decades of exciting advances in the technology of imaging. And now this next phase is taking all of this data that we get from a modern digital tomosynthesis mammogram, or from a high quality ultrasound, or for an MRI or a contrast enhanced mammogram, taking that and having a strategy that we can really safely say, you know, this woman really will do well with this particular fairly low intense screening strategy, where this other woman needs a more intensive screening strategy.
Thanks. And I guess we now all know how breast imagers or radiologists in general have a good time.
Exactly.
You know, I guess we all have our ways of filling up a dinner table's conversation. So, Susan, can you just comment on how research for one group of breast cancer patients, let's imagine either patients with BRCA mutations or patients with ER-positive breast cancer, you know, any group, can benefit others with breast cancer?
Absolutely. We had the challenge of the mute unmute. You know, this is now the new sixth grader skill set. I'll give you a precise example, which isn't directly in breast cancer, but is helpful. When we are looking at BRCA1 and 2 mutation-related cancers, drugs were developed to specifically target the cancers with those gene mutations. They're called PARP inhibitors. And they were developed with BRCA1 and 2 mutations in mind for very good reasons, because of the specific DNA damage deficit that was in the cells. And so we developed these PARP inhibitors. They get approved initially in BRCA1 and 2 related cancers. But now it's very clear that particularly in ovarian cancer, there's a large number of cancers that don't have BRCA1 and 2 mutations, but do respond to these drugs. We're still trying to sort that out in breast cancer. We haven't exactly identified which breast cancers that don't have these gene mutations will respond, but you have to dig deep on the science. So once you get a hit, if you will, once you have a positive result, you then have to say to yourself, okay, how else do these work? What can we do with them next? And another very good example is Herceptin and all these drugs against HER2/neu positive breast cancers. Well, they're used now in other HER2/neu positive cancers of different cancer types. So we really, as oncologists, sometimes, yes, I'm a breast cancer oncologist, but I really do try to pay attention to advances in other diseases because I'm never sure when it's going to cross over. And we have to be open-minded enough to say, you know what, that might be relevant. We might be able to use that information. So basic science, we can't say enough about that. The three of us are more clinically oriented, but we have our basic scientist colleagues. And sometimes you would never be able to guess what their work is going to lead to. I mean, you can't tell, I know science and I sit there and I say, how will this move from A to B? And yet circuitously it does. And so we have to be there on the other side to be listening to them and direct them into sort of the right area so that they can use their advances to help people.
Great. So I promised we would come back to this whole area of artificial intelligence, another approach that certainly was initially considered outside of breast cancer imaging. And I'm interested, Connie, and I think everyone listening will be interested, is what you're doing with artificial intelligence and some of your collaborators at MIT to ask new questions about the normal mammogram or MRIs or whatever. Oh, you're on mute.
Clicked myself. I thought maybe someone else had taken over that because I couldn't push the button anymore. I really like how Susan, talks about the importance of listening and paying attention to experts in different domains, because that's really where we are in healthcare with our friends and colleagues in artificial intelligence, and really having people such as Regina Barzilay, who's part of the research that we're doing in AI and breast cancer funded by the Breast Cancer Research Foundation, having this woman who was an expert at the top of her field in computer science and artificial intelligence go through her own breast cancer treatment and just say, can't we take what we're doing in artificial intelligence and apply it to help women who are at risk for and who are diagnosed with breast cancer? And that just started to open all of our eyes up to the possibilities. It's sort of interesting. The BCRF, a really strong member of the BCRF is Jack Cusack, and he some time ago said, why don't we take the breast density in the mammogram and add it into our risk models? And others have been noticing this as well. And so adding breast density to risk models makes those models more predictive, better. But what an amazing thing when you think about the richness of the deep, deep digital data in every woman's individual mammogram. And all we're doing is pulling out dense, not dense. It almost is going back to when we didn't have any imaging at all. And a woman whose evaluation for breast cancer was just, how did it feel in the breast, with having no x-ray, no mammogram, no ultrasound of it. We would just scratch the surface of that. So that's what has gotten us really excited. We're realizing with the tools of artificial intelligence, we can actually move from the revolution in improved technology, bringing more data forward, to now this revolution of having artificial intelligence tools to extract that data to predict the future. And we are amazed at how quickly this work can evolve. So Terry King at Brigham, and with her early detection program, where she's a strong partner in the BCRF work that we're doing, is really looking to how can we bring this data out of the mammograms and bring it into these patients that she's been working with, trying to prevent, have early detection, have better strategies. So it's a huge field. It's a big domain right now. We're most focused on the huge value of the quality and quantity of digital mammograms that we have and known outcomes of patients. And we're just delighted with how many people are excited and interested, because it's more information that we can merge with other big data sets to really be more precise and not leave all this information inside the mammogram, but extract it out and pull it forward.
I think we've all been fascinated by the work that you and Regina have been doing together, and it's great. So the next question is actually one that I will start off to answer, and it's what advice would you give to a patient with metastatic breast cancer and their families? And I was just trying to figure this out. So I'm 63, and my guess is that I have spent at least 5 years of my life in terms of total number of minutes taking care of patients with metastatic breast cancer, and maybe more than that. It's certainly been a large part of the time that I have spent professionally over the course of these many years. So metastatic breast cancer, as everyone knows, is breast cancer that has spread outside of the breast and to distant sites, to the bones, to the lung, to the liver, to the brain. And typically, we think of this as an incurable condition. That said, it is a very treatable condition for many, many women. And for years, we were always afraid to acknowledge that we thought that our treatment made people live longer. We thought that if we compared no treatment versus treatment, that almost certainly what we did for people would make them live longer and live better, but we didn't truly have proof of it. And now we do, unequivocally. And in the past 5 years, there have been multiple large clinical trials, each of which has demonstrated that by changing a drug or adding a drug, that we are able to improve survival, and in some cases by a substantial amount for women with metastatic breast cancer. It doesn't change the fact, though, that at least at this point in time, for the vast majority of women, even though the cancer can be controlled, and sometimes controlled for 5 and 10 and 15 years, and in some rare cases well beyond that, it ultimately threatens someone's life, and this is what we desperately want to do research to avoid. And so there is a tremendous effort going on in drug development and understanding resistance to therapies to try to really do better by people. And I'll share with you the fact that there's even thought that for women who, when they're newly diagnosed and have metastatic breast cancer, so they've never received any treatment before, that there may be even a subgroup of those patients where we perhaps should think about things differently and should take more of a curative approach in those individuals. And there are clinical trials that are going to go on that will address that. I have to say that as a clinician, taking care of patients with metastatic breast cancer is both one of the most rewarding things that I do in my life, and also one of the most challenging, because of course, as a clinician, you get very close to people and to their families. And you see that at times they don't do as well as you would like. But I do think it's very, very important for people to remain active and hopeful and optimistic, because the truth is you just don't know what's going to be around the next corner. And given the pace of research, if someone who's newly diagnosed, for example, with metastatic breast cancer, can live for several years, we don't know that there isn't going to be a better treatment in several years that's then going to be the curative approach. So I'll stop talking in just a second, but I would tell a newly diagnosed patient that in fact, this is a challenge, and that there's good reason why it's very disheartening, but at the same time, one has to go ahead and live one's life and be very hopeful about the future. I don't know if others have comments. Susan, I mean, Connie doesn't do this on a daily basis. You do.
Well, just as a historical perspective, HER2 positive breast cancer used to be our worst cancer. And now we have so many options for HER2 positive breast cancer in the metastatic setting, which is completely different than, again, even when I was doing my training. But the other thing is that, it's like Eric said, try to get educated, enroll in clinical trials when you can, because clinical trials and research are our path forward, and find a team that you have a good relationship with. Your oncologist is going to be your oncologist for the long term, and so you better like them. And if you don't, find somebody else.
There we go. I often tell people that when you're healthy, the amount of your quality of life pie, if you think of quality of life as a pie that can be divided up into little pieces, it doesn't really matter who your doctor is all that much. But when you have a significant medical problem, that relationship with the healthcare team is critical. So we have 2 minutes left, and we're going to do a so-called lightning rounds question. And this is, why should people participate in clinical trials? What's in it for them? What's in it for other people? Just quick thoughts about this, and then we'll wrap up. Connie, there are clinical trials in imaging for sure. Why should somebody do that as opposed to just get standard imaging?
This is how we learn, we get better. So many of our trials actually are helping women now. I think back on the clinical trials in MRI where those cancers would not have been found except the advanced imaging we were doing in those clinical trials, and especially when our clinical trials engage the full diversity of women at risk for this disease. And we're doing a lightning round. I have to give a shout out to say to all of you that are watching tonight and to the BCRF, let's please remember also to come in for screening. Right now, during COVID, we're in a window of safety. Hospitals and breast imaging centers all over the country have mitigated the risk of COVID. We are very concerned. We're finding at our center, we are finding cancers at later stages. We are screening less women. We are finding overall less cancers at our whole institution. Across the country, in the spring of 2020, the cancers diagnosis were half of what they were in the spring of 2019. The cancers are still there. We need to have safe ways to screen women, and we're so grateful. We're using some of our AI technology to bring the right women in while we have such limited access. So clinical research trials are so critical. And then also, please continue to be screened while we can.
And Susan, from a medical oncologist standpoint, why should people participate in trials? You and I both enroll dozens of patients in trials every year.
Just as a reminder, we never open a clinical trial unless we think that it might be better than the standard of care. We don't know it's better than the standard of care. That's why we're doing the study, where we talk about being in a position of equipoise. We're not sure. That's why we have to do the trial. But I can assure you that we never open a trial if we think that the other arm is worse. So we're always trying to get better. We don't know that it will help you. We don't know that, but we hope that it will help future women who are going through this. We want it to help you, but we know that the answer to the trial will give information that will be helpful to others. So thank you all those of you who have been in clinical trials. We are immensely grateful and always a little humbled when people come on these studies. So thank you.
And in truth, as you alluded to, it does help. The trials do help many people. And the reason we know more about breast cancer than we do about almost any other malignancy is because women and occasionally men with breast cancer have stepped forward to participate in trials. So our time is up. We really appreciate everyone listening. Just a comment about COVID. It's going to end someday. Unfortunately, breast cancer isn't waiting for COVID. So there are still cases of breast cancer. We still need to take care of patients. And there are even some data that there may be more cases of advanced breast cancer diagnosed today than perhaps a year ago. Maybe that's related to the fact that there's been far less screening. And it just means that the work that we do is going to be that much more important in the future, and we need to continue it for the moment and for quite some time to come. I want to thank the audience for all your support. Without your support, the BCRF couldn't do what it does. and we wouldn't make the kinds of strides that we have made and we anticipate making in the future. We hope that this has been helpful tonight. I got a chance to see my friends Susan and Connie, but I hope you enjoyed it as much as I did. Thank you so much.